Professor Mikkel Brabrand, a very good friend of our unit here in Hong Kong. Mikkel is a professor of emergency medicine at the University of Southern Denmark, and he was the research director of the Hospital of Southwest Jutland, and he's now at Odense University Hospital in Denmark. He's a good friend of mine and of the unit. He was spent nearly a year with us here in Hong Kong just a year or two ago before the pandemic struck. Your timing was good, Mikkel, I have to say. He remains an adjunct professor in our unit. So Mikkel's going to talk to us about big data and research in emergency medicine. It's a pleasure to have you here. Welcome, and we look forward to your talk.
Thank you, Colin, so much. Could I be allowed to share my screen, please? I'm not sure if I am.
Oh, you can.
Can you see it?
We are good.
Excellent. Thank you so much. And thank you for the very kind introduction. It's going to be a little bit difficult to live up to that one, but I'll give it a shot. So big data and emergency medicine. I have no conflict of interest, Jeff. I guess you have to say it now these days. So let's start with finding out what is actually big data. And big data is defined by a person called Charles Fox in 2018. Where parallel computing tools are needed to handle the data. And hang on, I'm just have a problem of something covering my screen. Well, I'll figure it out. It's something about data velocity, it's something about data variety, and it's about data size. So how much data can you get your hands on? How soon can you get it? And how varied a data set do you have access to? And that's basically what I'm going to talk about today. So big data can be many, many things. And in healthcare, we have an abundance of sources we can look into. And of course, we have our electronic medical record. Hospitals still are not completely electronic, but a little part of the world is digitalized. So I can access almost anything, pending that my hospital remember to pay for the data extraction possibilities as well. And that's sometimes forgotten. You can get access to test results if these are digitalized, both in our world, radiology or biochemistry, even blood cultures are now digitalized. We can get our hands on vital signs. These are all stored in huge databases that we can access in various ways. We have a way of digitalizing ECGs now. These are not just printed out, but actually computed, stored, and analyzed. And then, of course, in a few countries, you have huge national registers where everything is recorded on everyone. I'm going to come a little bit back to this, but here in Denmark, we have the National Patient Registry, which basically contains information on everyone residing in Denmark, going back to the 70s, on any healthcare contact they've had in hospital or GP services or in private practice. So we know almost anything medically about our patients, and they just added on prescriptions and biochemistry as well. So we now have access to an abundance of data here in Denmark, and we've used this to publish some and more currently in process. And then, as Dr. Liu mentioned before, wearable devices are going to be an immense source of big data in healthcare because everyone is wearing a device. I have my iPhone, I have my Apple Watch, my sons have their Android phones, and these are all registering data on them and on everyone else. And this will be a very important source for data for us in the future. And of course, we can do AI on most of this, and that's probably the way most of it is going. But I'm still somewhat interested in the old-fashioned research as well, but doing a bit of AI research. And I must agree with Dr. Liu. I don't think clinicians should understand AI because I certainly do not. Now, most of what I'm going to cover today is what could be classified as big data. And most of it is of a retrospective nature. So we're looking into data collected already. Now, as you all know, this limits us in some ways because we can more associations than causality. And that's just the name of the game using the data we have. And as such, we won't be on the top of the evidence hierarchy in what I'm talking about today. We will not be able to do prospective randomized controlled trials. But there has been developed ways where you can analyze observational data and approximate the RCT design, so you can get two populations that are very comparable and analyze them, for instance, through propensity score matching. I'm going to talk a little bit on it, but not much, but there are ways, and data science is constantly developing. But still, with all these limitations, there are many, many things we can do. We can still answer like effectiveness about healthcare utilization, about use of test results, changes in care or changes in availability of care, or even emergency care or emergency medicine itself. And I'm going to touch on each of these 6 topics throughout my talk. Now, if we talk about effectiveness, I'm sure you're all aware that in the UK and in many other countries, they have a 4-hour target. You have to be out of the ED again within 4 hours after arriving. Now, this was analyzed recently by a group of British physicians looking into the association between patient delay in the emergency department and 30-day mortality. Now, the 4-hour target was introduced in 2004 in the UK. And has been very vividly reported in the lay press and on social media. It's becoming increasingly difficult to reach this target. And this is not just for the UK, we experienced it within our unit as well. Now, they included all major EDs in the UK and defined major EDs as a unit that had consultant cover in emergency medicine 24 hours, and looked at data from 2016, April 16 till March 18. And that included 27 million attendances. Now, in my world, that's a big data set. 27 million is more than we see, to be honest, but they also had 7.5 million admissions, %. And due to the analysis they performed, they included the first contact of each patient. So they had 5.2 million patients in the data set. Now, out of these 5.2 million patients, they had 333,000 or 34,000 deaths within 30 days. So they had a crude mortality of about 8.7%. And that's pretty close to what we see in Denmark as well. So this would be in some regards comparable to my world. Now, they wanted to adjust for a few things because a patient attendance is not just a patient attendance. It depends on who the patient is and what the unit is like. So they decided to calculate the standardized mortality ratio, or basically a prediction of the mortality for the patients, everything else kept equal. So they predicted the mortality using age, sex, deprivation, previous attendances, and comorbidities, but also took other things into account like temporal factors and ED factors. So what month was it? What time of day was it? And how busy was the ED? And based on this, they calculated the standardized mortality ratio, or the SMR. Now, these are the results put into one figure. And on the y-axis, you've got the SMR, and you should be about 1 the way they've calculated it. And you can see the cutoff here. And then you have the waiting time, or the time in the ED on the x-axis, from 1 hour, 2 hours, 3 hours, and 4 hours. Here is the target in the UK. Now, as you can see, within 4 hours, most of the standardized mortality ratio counts were below the predicted value of 1. So people staying shorter than 4 hours had an increased survival. However, once you crossed the 4-hour target, especially the 5-hour target, mortality steadily and regularly increased for every hour you spend in the ED, up to 12 hours, where the data analysis ended due to the availability of data they had. So being delayed in the emergency department beyond 4 hours is associated with increased 30-day mortality, at least in the UK population. And this is a linear increase in mortality. So if you calculated the standardized mortality ratio for each of these, you had a survival effect if you spend less than 4 hours in the ED. But as soon as you spend more than 4 hours, your SMR increased by 6%. It was 4 to 6 hours, 14% for 6 to 8 hours, and 16% for 8 to 12 hours. And if you then calculated what this meant in survival, well, their conclusion says that for every one patient who's for every 82 patients who are delayed for more than 4 to 6 hours, there is one excess fatality. So this is actually patient dependent. And this is interesting because for us, delays are something that's impractical for the patients, but not something we thought would be associated this strongly with mortality. Now, there are a few caveats because they couldn't control for the morbidity or how sick the patient was. And the explanations are all speculative, but it could be exit blood, it could be lack of ED space, it could be lack of physicians in the unit. But there's definitely what seems like a strong association between patient delay and mortality. So what about healthcare utilization, or can you reduce ED attendances? As is seen in the UK and as we're experiencing in Denmark, we're becoming increasingly popular in the emergency department and increasingly busy. So is there a way to reduce attendances without causing increased risk for the patients? Now, we actually did this in Denmark, and we decided to analyze it with access to a huge data set we have that's basically a copy of the National Patient Registry for a very long period of time. So we tested if mandatory referral for unplanned hospital admissions was associated with a reduction in attendances. So can you actually tell people not to come to the ED? Now, from October 2011 and 3 years forward, the Danish government decided that you had to have mandatory referral before attending an emergency department. So you had to call your GP or to call a GP out of our services or request an ambulance to be admitted to the emergency department. Now, it has to be said that all Danes have an assigned GP, so we all have our own GP that we can talk to. So it's not that it's a burden for patients, they just have to call ahead. This is implemented because we see the GP as a first line of defense, and much of the stuff that you see in ED could actually be handled by a GP, and therefore that might be cheaper and better for the society. We looked into data from 2007 until 2017 and used 4 out of the 5 healthcare regions in Denmark. And the reason we didn't include the 5th was that they have a different system, that's Copenhagen. They have a different system where the out-of-hour services are treated in the ED and therefore not comparable to the rest of the country. Now, we included 7.5 million attendances over this period of time with a mean monthly attendance rate of about 3,500 attendances per hospital with a range of 1,000 to 5,000. And implementing mandatory referral, controlling for everything else we could come up with, and that was a very long list because we had a lot of data on these patients, found a reduction of about 10% of 9.4% of attendances per month per hospital. So we saw 10% fewer patients than we otherwise would have done. Now then, of course, the worry would be which patients then didn't come to hospital. And if we look into that, on the left-hand side, you have the ICD-10 chapters, and the patients who didn't come were mostly injury and poisonings, and that was usually minor injuries. Now, the populations that didn't come were both sex, mostly the young, mostly the ones with medium education, and the one with a low comorbidity score. So basically, implementing mandatory referral reduced the number of attendances about 9.4%, mostly in the ones with minor injuries that were young, medium educated with low comorbidity. And we haven't published in this one, but we looked at the population mortality at the same time, and there was no effect on mortality. So what about big data and test results? Well, let's collect some ECGs. We all know that QTc prolongation on an EKG is associated with a poor 10-year prognosis. But as an emergency physician, I cannot admit a patient for a 10-year prognosis. I need to know what's going to happen on the short term. Otherwise, I'm going to fill up my hospital with very, very long admissions. And our general admission is about 3 days now, so we have to get people out quickly. So this group looked into ECGs. They collected from 2 Danish and 2 Swedish hospitals and looked into 100,000 patients and analyzed their QTc using the Framingham formula. Now, 93% had a normal QTc, 6.5% had a moderate increase, and only 0.6% had a large increase or a significant increase in QTc prolongation. These were standard medical ED patients, so median age of 60 years, and 48% were male. Now, the mortality wasn't that bad, luckily, but it was still 1.3% overall for all-cause mortality, and disregarding whether they died in hospital or not, because we had access to national registries. If you had a normal QTc, your mortality was 1.2% within 7 days. If you had a moderate QTc prolongation, it was 2.4. And if you had a severe, and that was more than 500 milliseconds, you had a 4.3% mortality. Now, looking into hazard ratios, the hazard ratio increased from 1 for the normal to 3.7 for a severe QTc prolongation. And if you adjusted for age or sex, or even added prior diagnoses or pharmacotherapy or CRP, we saw some reduction in the hazard ratios for mortality, but still had a very, very significant association between QTc prolongation and mortality. Now, interestingly, they looked into the cause of death for these patients, and very, very few, it's less than a handful of these 1,300 people died from arrhythmias. Most died from infection, some from cardiac causes, but not arrhythmias, and some from stroke. And then, of course, an abundance of other things. But very few died from arrhythmias. And this to us is an indication that QTc prolongation is associated with fatality, but is probably a proxy for severity of disease more than a risk factor of its own. And this is actually what we started to see when we look for it in clinical practice. We see an abundance of patients with QTc prolongation in the EEG that are pretty sick. And once we stabilize them, their QTc goes down. Now, what about changes in care? Can you use this to analyze patients? Well, as you all know, in 2010, this was published in BMJ looking at high flow oxygen versus titrated oxygen for COPD patients. The study showed that you had a decreased mortality the oxygen for COPD patients. And this formed the basis for the guidelines for oxygen therapy defined by the British Thoracic Society, which then again informed the entire world, and they all follow the BTS guidelines for oxygen therapy. Now, their guidelines say that it's a grade A recommendation to use targeted saturation 88% for patients with COPD if you give them supplementary oxygen. Now, we only have this one study to look at. There have been studies, retrospective studies later, with conflicting results. Some show an increased mortality, some show a decreased mortality. And we're trying to do a randomized controlled trial proving this study, but it's very difficult. So we decided, can we do something else? So we looked into the national databases again. And luckily for us, the biggest ambulance provider in Denmark, on the 26th of September 2012, overnight changed their guidelines for oxygen therapy for COPD patients. So before then, they had to give, the paramedics have to give free flow oxygen for COPD patient exacerbations. And afterwards, they had to give titrated oxygen, so 88 to 92%. Looking into this, we found 413,000 admissions with COPD exacerbation. 37% of them, median age was 74%, and 47% were male. And the in-hospital mortality was 7%, 7-day mortality was 4.5%. Again, this is all cause, full follow-up 7-day mortality, and 3% had intensive care. Now, the study was done using something called event type analysis, or it was inspired by it at least. But here you have the crude in-hospital mortality with I'm sorry, the scale's a bit off, but this is 0.5% mortality, percent point mortality reduction, and this is an increase. This is before the intervention or the change in oxygen, supplementary oxygen. This is the time of the change, and here you have the time after. And as you can see in unadjusted analyses, there's a steep decrease in mortality, in-hospital mortality, 2 years after the oxygen therapy was changed. We then controlled for sex, age, education, childhood, income, ethnicity, and marital status, and we still had somewhat the same results, however, less significant. 7-day mortality was less, the picture was less clear. So it was a strong association. But interestingly enough, ICU admissions went down almost 2%, again, controlling for everything as well. So apparently there is some sense into using titrated oxygen compared to free flow oxygen for COPD patients. Now, then what about changes in availability or the access again to healthcare? This is big data because now we're talking maybe on a national level. And in Ireland, they did this. Ireland is a small European country with about 70,000 square kilometers and a population of 4.8 million people, very comparable to my neck of the woods. But they are very, very busy. They have a bed occupancy rate nationwide of 95%, at least when this study was published in 2020. So they had very limited reserve capacity in their healthcare system. And therefore, they called the study of the impact of reconfiguration of emergency and urgent care networks, or the SIREN study, which was a huge conglomerate study using a mixed methods design, where they looked into what were the effects of changing care, or changing the availability of healthcare anyway. Now, prior to 2006, Ireland had 35 EDs that were open around the clock, consultant-based, and 3 children's EDs. This was changed over time afterwards, where they either closed or redesigned the rural EDs and went down to about 25. Now, redesign more or less meant that they were only open during daytime and closed at night. They looked at overall mortality and then 16 different, what they call serious conditions. And I'm just going to touch upon a few. Now, this is the mortality. And again, they needed to dice this like they did with SMR before. And therefore, they calculated the case fatality rate, or the CFR. Here you have the age and case mix adjusted per 1,000 people, and therefore the deaths and time on the x-axis. Now, before this was implemented, they saw a steady decline in mortality from about 185 in CFR to about 163 or so. And then this decline actually leveled off after and during the reconfiguration. So the reduction in mortality wasn't as strong during the reconfiguration as it was before. Now, the problem with this kind of observational data is you're not sure what you're looking at. And at the same time, as I'm sure you're very much aware, this was a financial crisis worldwide, the 2008 collapse. And therefore, they were struggling financially in Ireland, especially in Ireland at that time. And therefore, this might not just be the effect of the healthcare reform, but also Ireland as it is. If you look into stroke care, the reduction in CFR is steep and comparable to the other, the total, and then it leveled off again, just like we saw with the overall mortality. But if you look into AMI or cardiac arrest, the decrease was continuous. And the authors prescribed this to being implementing around-the-clock access to primary PCI throughout Ireland. So you can actually use big data and nationwide data to see, to challenge the effects of healthcare reforms. We've done exactly the same in Denmark from 2007 till 17, where we spent almost 65 billion Danish kroner. That's almost comparable to Hong Kong dollars, and have shown very little effect on mortality. So what about emergency care on itself? Now, the observant listener will say this is not big data, but I still think it's interesting, and it's touching upon big data. So what about the healthcare we provide? Now, if we look at healthcare as it is, we of course expect, especially our students and junior doctors, think that everything we do is based on high quality evidence. But if you look into it, studies suggest that about 7% of sepsis care is high quality evidence, 8% of cardiac care is on high quality evidence, 10% on ICU care, and the top scorer, as far as I am aware, is oncology, with 15% of their recommendations actually based on hard evidence. So what about emergency care? Now, before I found the study I'm going to refer to you, my guess would be low in single digits. But actually, a group of the US looked into this. So a group out of Stanford did what's called an umbrella review of the effect size biases and power across meta-analyses in emergency medicine. And they went out of their way to find as many meta-analyses from emergency medicine, from especially the big journals, across all emergency medicine, as they could, at least from 1990 until 2020. And they found whatever could be found, or more or less. Of course, you can always argue about the search strategy, but they had a comprehensive search. They found 431 meta-analyses that they could include, and these were on 350 different topics. Now, the studies were, of course, of varying size, but the median sample size was 114 participants in each study. And each meta-analysis had a median number of studies of 6. So if you calculated this out, you had a median total sample size per meta-analysis of 1,000 patients, ranging from 400, or IQR is 468 to 227,200, sorry. Now, if you look into the studies, 28% of them, or 39% of the meta-analyses, had significant results. And after 28% of the studies that had significant results, 14% favored control interventions, and 10% of the meta-analyses with significant results favored control interventions as well. However, a sub-analysis of the power of these publications showed that only 18 were actually sufficiently powered for what they were looking into. So the quality, I guess you could say, could have been better, I guess. Now, if you look into the 430 meta-analysis, how many of these would you say of high quality? 12. And that leads us, if we compare to the studies from the other areas, of a 2.8% high quality mark. So we were in single digits, and we fortunately are not where the other specialties are again. So that leaves room for us in emergency medicine research to improve care. Now, if you look at the 12 studies that actually had high quality, these were on very many different topics: interventions for alcohol consumption, CPR for out-of-hospital cardiac arrest, thrombolysis for STEMI, pulmonary embolism, how to keep patients from leaving without being seen, and so forth. So these were of many, many different topics. And I guess this reflects emergency medicine. We have a broad spectrum of care. So to round this up, big data in emergency medicine research can answer many interesting questions. What I presented here and most big data studies are unfortunately on retrospective nature, and they require access to large data sets. And as you can see by the first definition, require a lot of computing power. And we still need to answer 92% of the questions we face in emergency medicine, I guess you could say. But what I've answered today is that a delay beyond 6 hours is bad for you. Mandatory referral will be used. That QTC prolongation is associated with short-term mortality, and titrated supplementary oxygen for COPD is probably the right choice, and that a national reorganization of healthcare might not change much mortality-wise, and that we're definitely not based on strong evidence in emergency medicine. Thank you.
Thank you very much indeed, Mikkel. That was great. Your last message reassures me that we're unlikely to be unemployed anytime soon as researchers in emergency medicine, which is great. I don't see any questions coming through on the chat, but I have one for you just before we wrap things up for this session. You're talking, as many of our speakers have over today and over the last few days, about big data. It's maybe a trite question, but what volume or sample size constitutes big data?
Well, the official definition was that we're looking into, you need parallel computing to analyze it. So huge data sets, gigabytes, terabytes of data is what would be the definition of big data. However, some of the stuff I've presented here can be done on a desktop computer. Might not just need to run for a few hours to do the analyses. But it's a flexible measure, and you can do it in megabytes even if you have enough data points. It's just a matter of what data you have access to.
I mean, I was a few days ago, CT Loy from Toon Moon Hospital over here he set up and leads the big data setup in the hospital authority. And he introduced me to two new words that I'd never heard before, the petabyte and the exabyte, which are even more than the terabyte, which I had to go and look them up. And you know, it just brought home to me the volume of data that we're generating on a daily, weekly, monthly basis. So I guess then that answers my second question, which is you mentioned about the computing power, but does that then have, what's the effect on the statistical techniques we should be using? Is that where we need to go into machine learning and neural networks?
I think if you want to go, I'm not sure, I think much of this can and have been handled using traditional statistics. I think it depends on the question. And I think in my respect, it depends on what you want to know. And we're using AI into big data sets to answer new questions, to find patterns and connections that the human brain isn't capable of finding. If we use traditional statistics, we have an analysis plan, and we go the path we decided based on our experience and our prior knowledge. If you apply AI, you get patterns you haven't thought about before. They see connections that we haven't been able to see. And sometimes using this black box mythology comes up with something about connections we didn't expect that are maybe more powerful. And we've even used it to a little extent on the thermography you talked about prior, and are using it now, because we had a hypothesis that you should look at some measures, supercomputer in Denmark to have a look at the same photos and say, what would it be, that suggestion on which connections to look at. Now, we don't have the results yet, but I'm looking forward to see if I was right or if I missed the point.
Fair enough. That's excellent. Great.
I think Kevin is raising a hand.
Yeah, thanks, Mikkel. Very interesting. Given what you said about, you know, the number of big data we have, like you just mentioned about ECG, and I think apart from QTC, there's a lot of more finer details that we probably can look at. And you know, the point about thermography, it's, you know, there is a lot of data points, and we probably haven't made use of all the, you know, finite or minute differences. Do you think that, how best do you think we go about with so much data available to us? How it comes back to my question to Dr. Liu as well, because using traditional statistics, it's very hard to take into all these factors and try to explore, you know, patterns. Perhaps we need new techniques, or it's not so much hypothesis testing anymore, right? In some ways. So I'm just curious, you know, what do we need to do to, you know, make best use of the data we have, or that we can get our hands on?
Yeah, I think it comes down to what I've been spending more and more of my time on is not doing analyses, but trying to find the question I need solved. So because we have so much data on our hands, I now have a copy of every healthcare contact, every blood test for the entire population over a 7-year period. I can answer any question I want to, but I need to ask the right question. So I think it's finding the question that can actually change care for my patients. And that's what's becoming increasingly difficult, because we can ask so many questions, we need to find the right one and then dive into that one. So we're having strategies discussions, we're having meetings, consultancies about what one thing should we go into. And I've suffered from the same as Tim Rainer has, that I've looked into everything, and we need to focus on topics. So I think we can answer almost any question we want to now using big data and AI. So let's find out what the one thing we need to find out is what can actually change care for our patients. And we have the struggle about doing RCTs at the moment, that we're using mortality as an endpoint. But we have a very, very low mortality in Denmark. I mean, healthcare is quite good and it's free of charge and it's free of access to everyone. So maybe we shouldn't look into mortality anymore, but need to find other endpoints that are actually important for our patients. Quality of life, independence, stuff like that. And that's a novel area for us because we've always done what we've always done. But if I want to look into high-risk situations, I'm looking at aortic dissection or major trauma or cardiac arrest. And these are very sick people where I have to come up with something extremely out of the ordinary to help them. So if I want to help the everyday patient, I need to think out of the box.
It's always reassuring to hear that you have the same curse as the rest of us, the desire to investigate everything. Kevin, you have a follow-up.
No, I just see W on the
Yes.
screen, so I'm not sure if he has anything to supplement.
Yeah, thanks. So I think so because the booming of the data collection nowadays, right? So we're facing a lot of issues. We don't know what to do. So traditionally, research are usually hypothesis driven, right? So we have a very clear mind before we conduct any data analysis and even study design. So, but when the data becomes big, I think one of the issues that when we use a traditional statistical analysis is that p-values usually becomes very small. And some of the factors that, with the smaller data sets are not considered as significant, but when the data size becomes larger, it becomes significant. But in the real situation, so we don't know. Right, so I think these are the questions when we deal with the big data. But as Dr. Michael mentioned that, that's the big data opens up many opportunities for us to explore. So we can make do a lot of statistical epidemiological analysis with the availability of big data. But coming to the topic of AI and its analysis for big data, so my thought is that. So the size of data is not the key issue. The key issue is whether the data is representative or not. For example, in our analysis, so we have access to roughly, let's say 1 million patients data points. So when we build up the same model, actually we found out if we only use 10,000 patients to build an AI model, which has a comparable performance with a model built up from 1 million patients, as long as the data points are representative. So it is fairly important that the people always rely too much on the data size rather than looking to the representative of the data. So if the representative of the data comes back to the question of with the clinical inputs. So that is the reason why data scientists should really work with a clinician to find out the best representative part of the data that we can use AI to address, or even use a traditional clinical analysis methodology.
Excellent. Thank you very much indeed, both of you, Dr. Liu and Professor Mikkel Brabrand. They were both excellent talks. That's been a very, very useful and fruitful session with lots and lots of potential for future work and collaboration. And again, I'm very reassured that I'm not going to be out of work anytime soon in terms of the volume of things that we still have to look at.